Gracias. Okay, so tonight we're with Dr. Michael Ivan. Thank you, Michael, for accepting this invitation for this lecture. So my name is Edgar Ordóñez from Bogotá. I'm a neurosurgeon at Hospital de San Jose. We have had this webinar since the pandemic started. So Michael is going to talk about maximal safe resection of high-grade gliomas. So Dr. Ivan graduated from Rutgers University and completed his neurosurgery residency at University of California, UCSF, and completed his fellowship in neuro-oncology at University of Miami, and is currently an assistant professor at the University of Miami and works in the Jackson South Hospital. And so he's chief of cranial neurosurgery and neuro-oncology service and co-director of neurosurgery. And he's also director of research for the University of Miami Brain Tumor Initiative within the Sylvester Comprehensive Cancer Center. So Michael, thank you very much again. And please go ahead with your talk. It's a pleasure for us to have you here.
Thank you, Edgar. It's really a pleasure to and an honor to talk to you guys tonight. And sorry I can't do this in Spanish, even though I'm in Miami here, and my wife is Spanish speaking with our kids at home all the time. I still only have my numbers and colors, but hopefully you could appreciate what I'm trying to say today. And it's very kind of near and dear to my heart to talk about maximal safe resection for high-grade gliomas. My research in my research laboratory here at University of Miami is devoted towards glioblastoma and the invasive characteristics of gliomas. And so obviously understanding how as a surgeon we can improve quality of life and outcomes, that's important. I also want to thank my fellow Dr. Eichberg, who's now in his research year in the lab, who helped me put this talk together. So just some disclosures real quick. So we're just going to quickly go over some of the literature for extended resection, and then going over some of the ongoing advancements in imaging, surgery, and treatment with these tumors. And of course, if anybody has any questions, this is very informal, so please feel free to interrupt and ask questions. I mean, glioblastoma right now, surgery is a large part, but with the development of new therapies and whatnot, I appreciate, I assume in the future that this is going to become more of a precision medicine, and I don't think surgery is going to be the mainstay of treatment. This idea of this walking in with your genetic sequence of your tumor into a pharmacy and giving them your sequence and then giving you a targeted therapy has been around in theory ever since it was talked about in the early 2000s. And although we're not there for glioblastoma, I think we are there for many other kinds of tumors, and I think it's a matter of time before we get there. I don't think I have to introduce to this crowd what glioblastoma is. It's the most common, most aggressive brain cancer that there is. 65% of all brain tumors in the 5-year survival is dismal, less than 5%. Standard of care has been basically unchanged for the last 25 years and consists of radiation chemotherapy. And the interesting part to me is that when it does recur, which is inevitable, 95% of all the recurrences occur within 2 centimeters of the lesion. And I think that's one of the main reasons why a lot of the literature that I'm going to talk about next is there, because of extended resection means getting out all the tumor and supramaximal resection beyond what you see on the enhancing MRI, because of this idea that there's so much recurrence happening so close behind. This idea that the more you resect, the better off a patient does is not a novel technology by any means. I mean, it's been described in the late 90s, but it's really Lacroix's paper in 2001 in neurosurgery that really established this idea of extended resection. And this has been then published again multiple times in multiple iterations, also by the UCSF group when I was there with Dr. Sinai and Dr. Berger, suggesting that 78 to 80% is the kind of a big threshold in improving, kind of overall survival in these patients. And since then, there's been many papers that have been that have talked about this. It has expanded now into high-grade gliomas, low-grade gliomas, and glioblastoma. So just to illustrate that, here's this one review that was in JAMA in 2016, where they talked about all of the papers that have been published on this topic. And in total, it was 16,000 patients. And you could see here by the chart, all the papers by the forest plot showing the favoring of a gross total resection with surgery is by far helpful. But so I could just stop the talk there and say that, that's the goal of any surgery, but obviously there's a lot more to the story, and our patients are much more complicated in this aspect. And so one of the things that comes up quite frequently is, especially in GBM, is what does the contrast enhancing MRI really tell us? Is that the only part of tumor, or is the tumor beyond that? And what is it, the flare or the swelling of the tumor around this on the MRI, and is there tumor in there? And so this was a paper that was just published in Journal of Neurosurgery in 2020, talking about how this amount of flare and the ratio of enhancing to flare is important, and also at times the resection of the flare is equally as important as resection of the actual tumor itself. And what they did is they first they show here that resection of the contrast enhancing tumor, the more you get, the better the patient does with survival, which is what we know. And then they show an equal overall survival chart showing that if you early resect more flare signal, you also get a better improvement in better overall survival. And what you see is, as you would expect, is that there is a difference with the molecular subtypes of glioblastoma. We know that the IDH wild type tumors tend to do worst, and that those tumors are much more invasive. And so we know that the tumor extends well beyond the flare that you see on the scan just by the science. But we know that an IDH1 mutant is a much more slow growing tumor with a longer course, younger presentation. And we know that in those cases, the flare signal is really most likely just some swelling and not really tumor invading. In that way, if you get the enhancing part and a small amount of flare, you can actually provide more of a resection, supramaximal resection, which has an impact in overall survival. So taking that back to the next step, which is, okay, so beyond the flare, what is referred to as maximal safe resection or supramaximal resection is this idea of lesionectomy versus lobectomy. And so our group just published this in this past spring with looking at just tumors that are non-eloquent. So only tumors where you could really even ascertain the ability to get a supramaximal resection. So things like right frontal gliomas, right temporal gliomas, or occipital gliomas, where there's already visual deficits. And the question was, do you go in and just take out the tumor and maybe even a little bit of the flare, or do you do a supramaximal resection in these silent areas of the brain and do lobectomy? So only right frontal lobectomies, right temporal lobectomies, and occipital lobectomies were included in this case series. And so we looked at our 69 patients over the last 10 years, and there's 30 in each group. And we did see that, in fact, there was a significant overall benefit in overall survival as well as progression-free survival, as which you can see here. And even when we look at the molecular subtypes of the tumor, we again still see that lobectomy does provide a better overall survival and progression-free survival when it is a possibility. Now, obviously, you can't do this if there's any risk to the patient's function, but in these cases, we felt like a lobectomy would not offer any kind of cognitive or neurological deficits. And here is just kind of a blow up of that figure, which shows a couple of these lesions that could go either way. So this is one, it's a little bit far back in the frontal lobe, but here is a right temporal lesion, obviously, with a lesionectomy. Here's a right temporal lesion with a full right temporal lobectomy or anterior lobectomy. And then here's an occipital lesion here with a lesionectomy and an occipital lesion here with a lobectomy. So even pushing the boundary even further with glioblastoma is this idea of multifocal glioblastoma. And I think there's a lot of debate as to what to do with these patients, biopsy versus resection. And so we looked at our own series because we take a fairly aggressive approach here at Miami, which is what I've learned at UCSF. And we looked at our patients that where we were able to do more than just a biopsy when a large component of the tumor was resectable. So, and I'll show you. I'll show you a figure next. But if there was a multifocal glioblastoma, but 80% of it or 70 to 80% of it was thought to be resectable, then these are the patients that we included in this kind of retrospective cohort of biopsy versus resection. And so you see it was a small cohort, 16 patients resection, 18% biopsy. And this is kind of the breakdown of the resections. So we were able to get eight patients had greater than 85% of the overall enhancing tumor in the brain resected, and 9 with less than that. And the tumor sizes were very, if you add the entire volume of the tumor on both sides, it was very similar. And what we see again here is when you're able to get a meaningful resection, even when it's multifocal, you could still have benefit to the patient. Obviously, we're not curing these patients, but even any survival benefit is important to discuss, considering minimal benefit has been made in the last 25 years. But you can see here, biopsy and resection have done better. Here is a multivariate analysis when we look at kind of the size of the tumor, the patient's KPS, their age, and we still see that resection has a lower hazard. And then again, another multivariate analysis looking at extended resection, showing that when those 4 patients that we did get a greater than 85% resection, it appears that that does have a meaningful outcome for their overall survival. And again, this is just very preliminary retrospective data. A clinical trial really needs to be done. But here's a couple examples from this cohort of patients. So this is a 65-year-old gentleman presented with left-sided facial weakness and confusion. You can see here he has kind of this bilobed glioblastoma. If you come up maybe a slice, you could maybe say that there was maybe a small connection, but he also has this enhancing lesion in the contralateral left atrium. And so here's the surgery that was performed, a wake surgery for this right-sided large lesion, which is obviously more than 80% of the tumor bulk is on the right side in this one area, which could be a resected via one approach. And here's what the post-op looked like. So what happened? So, well, he went on to get standard treatment as expected. His tumor markers were MGMT methylated and IDH wild type. And, so he progressed. And I think progression-free survival is difficult in these patients because what are you talking about progression? His resection cavity didn't progress, but obviously the contralateral side did grow a little bit as he was getting treated. And so we counted that as progression. But overall, he did well. I mean, according to the glioblastoma numbers, and his overall survival was 30 months. And his ultimate area of progression was the contralateral side here. Here's another patient. Obviously, they don't all do well. A 66-year-old patient with first-time seizure, found to have this large right-sided lesion and homogeneous heminopsia. He also had a small enhancing lesion on the contralateral side here in the premolar area. So a large surgery was done because, again, we felt that about 70–80% of the tumor was on this one side and very surgically accessible. Then underwent additional therapy, did not resect the contralateral lesion, ended up having EGFR amplification and unmethylated and wild type, so not a good characteristic of gene profile here. Progressed, contralateral side progressed at 3 months, and his overall survival was obviously only 10 months. But I think understanding, and not just giving up on the patients which are multifocal are is a key next step in trying to ensure that we are providing the best possible care and providing the longest possible outcomes. So let's move on more towards how to achieve the maximal safe resection. Obviously, surgery is, again, a small part of these patients. Preoperative imaging is key to understand as much as you can about the tumor, surgery, and we'll talk about the surgical advances. And then after surgery, genetic understanding of the tumor, genetic profiling, and then the directed therapies that are available and new. Obviously, imaging is critical. I mean, here's 5 MRI scans, all with enhancing lesions, and only one of them is a tumor. And so the ability to detect this preoperatively and understand not only what is a tumor, but beyond, what is radiation necrosis, what is not, and only the one on the left here is a GBM. All the rest of them are not. So what we use is we do MRI perfusion on all of our preoperative patients and also during follow-up, and we found that using MRI perfusion helps to understand the ability to detect radiation necrosis after their initial treatment versus not, and this is a paper that we kind of showed about that. Additionally, we have a kind of 3-dimensional MRI spectroscopy here in Miami, which is able to detect kind of not only just the choline creatinine ratios, but also understand kind of things like the glutamate and alpha ketoglutarate levels or hydroxyglutarate levels to see if it's IDH1 mutated or not, even before you get in there, which will help you understand what is the flare signal. This is a clinical trial that we have ongoing, and we're hoping to kind of tune the MR spectroscopy even more to kind of understand some of the genetic profile of the tumor even before surgery. So obviously surgery is what's near and dear to our hearts, being surgeons. Our goal in these cases are to achieve the maximal safe resection. Maximal is really what the debate is. Is it gross total? Is it supramaximal? But overall, the goals of surgery are to provide diagnosis, relieve the mass effect, and improve outcome. We know that the most important thing is the word safe in that, because there's a paper out of UF by Dr. Rahman, basically looked at the same idea of this, does extended resection improve outcome, and she confirmed that. But what she then looked at was, okay, when those patients where you did try to push the boundary and they had a deficit, how did that then impact those patients' outcomes? And she found that when patients have a deficit, not only are their quality of life decreased, but their overall survival is too. And she showed that specifically by age group here, and by 60, 70, and 80-year-olds, whenever they have a deficit that is not transient, that is permanent, their overall life expectancy is almost halved. So how do you achieve the best maximal safe resection? And I think that the number one safe way to do that is with intraoperative stimulation. Again, this is a great review paper by Dr. Berger and Dr. Defoe in 2012, where they looked at 6,000 patients with gliomas and looked at with stimulating and without stimulating. And you could argue that the with stimulation ones are probably the eloquent tumors, which those patients would do worse because their tumors are more closely related to deep structures or important structures. But in fact, even in that cohort, they had less complications and less severe deficits, indicating that even in the worst case scenario, patients will do better with stimulating and motor mapping. So I think we're all very familiar with some of the advancements that have occurred in surgery, navigation, ECOG, direct stimulation, cortical stimulation, subcortical stimulation, tractography. But here are just some of the topics I'm going to touch on real quickly. The first is really awake surgeries, because I think we do that a little bit differently here in Miami than a lot of places. So typically, indications for awake surgeries is any patient with a lesion that's in proximity to language function on the left side. But we really have pushed the limits of awake, and really any tumor that's in an area where it's mappable for motor, sensory, or neurological function, we now do awake. So it doesn't matter right, left, or if it's interior or posterior, we still do them awake and map them out for all their abilities. And one reason why is because even when you think you know where Broca's and Wernicke's are for speech, you're only partially right. There's a paper by Eddie Chang and Mitch Berger looking at basically the chances of finding speech and language areas in this cohort of patients, and showing the diverse ability of mapping in those patients, and for Broca's and then for Wernicke's. And you could see that basically it was the entire temporal lobe here was getting patients that were positive for Wernicke's. So what kind of mapping do we do? I think obviously the most common is motor and speech, but depending upon where your tumor is, parietal, somatosensory function, picture naming, calculations, 2-point discrimination, temporal, again, picture naming, reading, and spelling, as well as memory, insular motor function, speech arrest, picture naming, reading, and spelling, and motor function for frontal, speech arrest, reading, and spelling. Especially a frontal in the premotor cortex, we found that by doing these patients awake, as well as with a backup of MEP, we could kind of identify when somebody has an SMA syndrome versus a permanent deficit by doing both awake and asleep mapping during the surgery to kind of understand if those tracks are still intact. We're publishing on that now. So contraindications and solutions for awake surgery is a great paper by Dr. Berger talking about his 27-year experience with awake surgeries. He definitely has one of the biggest series in the world. And in these concerns of if people with large mass effects, people with have large tumors and have large mass effects, what do you do? Obese patients, young patients, patients with psychiatric histories, smoking history, and basically how they've kind of dealt with each one of these difficult situations throughout the years. And this is a great paper to read for anybody who does awake surgery, just to kind of understand how to achieve the best possible outcomes for all patients, not just for the optimal patient. Also showing that the safety of these patients is extremely safe. They quote a very low rate of aborting an awake case. I think here our rate is somewhere between 5 and 9% of patients who can't tolerate it. But obviously, Dr. Berger has a much larger experience than we do. So our surgeries, we have no intubation, minimal general anesthesia, and we also try to, we found that with using awake surgery, it gets less anesthesia, and these people wake up quicker, and they're able to kind of partake in the next step of their treatment. And so we actually have these patients do physical therapy on the same day of surgery, immediately after surgery, and then an MRI the same night of surgery, and then they go home the next morning if they're intact. And this reduces morbidity and mortality. And we've shown that by looking at our series of over 500 patients, showing that about 75 to 80% of them are able to go home on post-op day 1 recently. This is back in 2015, but even more recently, this has gone up because of this ability to kind of prep the patient beforehand, select them, have a good plan. But the most important thing is the postoperative care, and having a postoperative care plan laid out even before they go to the surgery in the first place. Illumintide, this is just kind of the setup for our awake surgeries. Patient being able to be seen. We have our neurophysiologist here talking to the patient continuously. If they need to be reading, we have iPad screens that kind of we use to show the patient pictures and to work with their naming. So what other advanced neuroimaging do we use? Obviously, DTI tractography. But the question is really is how much do you rely on preoperative imaging to make those critical decisions intraoperatively? I think it's great for preoperative planning and to understand maybe where the critical parts are going to be and maybe how much you're going to have to leave. But you can't completely rely on either functional MRI or DTI tractography. And this is a great paper by Dr. Zhu in 2012, correlating DTI tractography to direct cortical and subcortical stimulation, showing that sensitivity is only 93%, and the distance between positive stim sites range between 2 and 14 millimeters, meaning that when you were stimming, which was kind of thought to be the gold standard, the DTI track on the MRI was measured up to 14 millimeters away in some cases. And so there's a lot of reasons why that could happen. Intraoperative brain shift or edema is not accounting for all of the DTIs, and it's limiting the tractography that you could see preoperatively. All that is important with understanding, but ultimately, your ability to do a great mapping of the patient, both at the beginning of the surgery and during the surgery, is what's going to be the most important thing. So this is a case that we had of a tumor in the motor cortex. Green was cortical spinal and red was sensory. We mapped it out here. And I think the next step is after you map out your tumor, and we use both kind of the Ogerman stimulation as well as monopolar stimulation. Ogerman stimulation for kind of the cortical stimulation, and then after we do the resection, we go to monopolar at that point in time because it sends out more of a beacon of stimulation, which gives you a little bit more real-time feedback. And then the other importance that I want to mention is the importance of intraoperative ultrasound. And the more you use it, even in cases when you don't need it, the more you become accustomed to it, and the more likely you could help understand the tumor borders as there is brain shift during surgery. We don't have an intraoperative MRI here, and so using intraoperative ultrasound is kind of equally, if not is as good as the intraoperative MRI. And so this is a resection cavity. But intraoperative ultrasound is moving just beyond understanding what the borders of tumor are these days. This is a great paper here by Dr. Prada showing kind of advanced ultrasound and the ability to not only detect kind of the tumor and large vessels, but also able to detect some of the elasticity, what tumor is firm, what tumor is soft, where the cyst would be. Here's showing for insular gliomas how they could detect with flow in the ultrasound the perforators coming off the thalamus striate arteries, and knowing where that border immediately would be during a resection to kind of prevent any injury. So it's well beyond just understanding what that gray and white boundary would be, but now all this. And there's ability to kind of now use ultrasound with correlation to your image guidance and to correlate the two and make ultrasound actually image guided tool, which is something else that's available. So again, in these difficult to resect tumors, here's a left-sided glioblastoma in a very difficult location, kind of spanning underneath. It is the arcuate fasciculus and the uncate fasciculus. You have maybe Wernicke's were below it, Broca's anterior of it. So your tractography is great. It'll tell you where the tracks may be. But the next part of really how we decide the tractography is understanding this idea of point of entry. And a lot of these tumors don't come to the surface, and sometimes the closest area is not necessarily the safest, but maybe looking down the length of the tumor and where the widest gap is between your tractography would also be an important point to come into. So here's another example. Is a 31-year-old patient presented with her first-time seizure, left-sided weakness in a large tumor on the right side. Here's the lesion. So tiny bit of enhancement just at the middle, but overall not enhancing. You could see very well circumscribed borders. You're very hopeful this is going to be a low-grade glioma. And important characteristic is you can't always trust what the preoperative MRI is going to tell you about low-grade and high-grade. We looked at our series here of 111 kind of non-enhancing gliomas that we did over the last couple of years. And of them, 40 of them, or 40% of them, ended up being high-grade gliomas, even with no enhancement at all. And this one has a little bit of enhancement. So not surprisingly, this ended up being a grade 3. You could see here the preoperative functional MRI and DTI tractography where the motor cortical spinal tracts would be pushed lateral and anterior, where this is going to be the most difficult kind of part of the resection where you have to be really, really careful. But obviously, complete mapping was done. And you can see the post-op scan here is exactly what you would expect, is that area where we found the DTI shows where the cortical spinal tracts is where we need to leave a small amount of residual rind there. But the rest of the resection cavity looks good. And she had a subtle weakness for the first 2 weeks after surgery, but then that improved, and now she has full strength. Her 1-year post-op scan is totally stable. She did get radiation and chemotherapy because it was a grade 3, but IDH1 mutant tumor. and there was a subtotal resection here. So what's another tool that could help kind of push you beyond the limits, and that's 5-ALA. We've been using this here for about a year and a half, and when I was a resident at UCSF, we were one of the first places in the U.S. that had it. I think the critical trial was with Dr. Stumer, who did the phase 3 clinical trial back in 2006 now, when they had it in Europe, comparing 139 patients where he did 5-ALA resection versus white light. And even in this case, kind of again, proving the fact that more resection offers some survival benefit. He did find that there was survival benefit in the patients where all the 5-ALA component was able to be resected in these tumors. And I think there's plenty of other trials after this that kind of looked at this in retrospective studies, but this was kind of the mainstay that was published in the Lancet. So how do you optimize your surgery? I mean, we talked about awake surgery. We use it very generously here. Preoperative advanced imaging is definitely great for guidance, but in many times it doesn't necessarily change what you're going to do in the operation. It just helps guide you towards the safe entry zones and where to use extra caution. Obviously, you want to employ and use subarachnoid planes as much as possible. Careful selection of the point of entry, like we talked about. Again, using direct cortical and subcortical stimulation as much as possible is key in all of these patients. I've adopted the fluorescence guided surgery. I find it very helpful, especially in these low-grade these intermediate grade, like grade 3 tumors, as well as all recurrent tumors and gliomas. Embrace the intraoperative ultrasound and take advantages of the functional silent corridors to achieve the supramaximal resection. I really do think that makes a survival benefit, not only in low grades, but also on high grades. And then really have the postoperative plan laid out immediately after surgery. There's no need to wait for the next day or two till the patient's comfortable to do that. The faster you mobilize them, the better they do. So looking ahead, what other technologies are out there to achieve a more maximal resection? And this is intraoperative kind of histology that we use. And this is called the Raman histology system, which there's a couple different Raman histology simulators now that are out there. And this is just one that we were lucky enough to use last year for about 6 months. And it's a way to get a quick intraoperative frozen slide. So as you know, frozen slide typically takes here anytime between 30 and sometimes 40 minutes to get the frozen slide results for a pathologist. And with this digitized system that uses Raman histology, you could get it less than 3 minutes, sometimes just 90 seconds immediately. And then with Wi-Fi, it goes to the operative room and goes up on our screen. So even the surgeon could see what the pathology is at the time of resection, not like a half hour later after you've already started working on another section of the tumor. And you can see here that the consistency is there's a little bit different in the way that these specimens look. I mean, here's what a normal frozen would look like for glioblastoma, and here's Raman. But if you look at kind of the consistency of normal brain to low grade to high grade, you could definitely tell that there is tumor here and that there's high proliferation. You could see necrosis, you could see pseudopallisating cells. Here's one left frontal glioma that we used it in, and you can see here the necrosis at the center. You could see kind of at the ring enhancing edge that there was obviously high proliferation of cells. And then as we get to the outer flare, you could see the density of the cells go significantly down. So, can this help in addition to 5-ALA to try to achieve these negative margins? I think definitely it can. We looked at it first just to understand if it was accurate and fast, and we did see that and we looked at around 80 patients that the specificity was 100 and sensitivity was 97.5 for making just a diagnosis of tumor and no tumor. But it also was able, the pathologist, and many times, about 93% of the time, was able to make the diagnosis. As well as the time goes, these light blue is kind of the time that it usually takes our frozens to come back. And then with the SRH, which wasn't even optimized, it was averaging about 7 minutes. But I think we didn't even have an optimized system where the Wi-Fi was set up with a pathologist. It was still calling back and forth. There's ways to get this down to less than 2 minutes. Obviously, there's a learning curve with both the pathologist and surgeon for using this, and it does take a couple extra minutes in the operating room, but overall it's time saving because you're getting your results so much faster. So the next step in this is can you use artificial intelligence to get the without even using the pathologist or just having the pathologist confirm this, and in fact you can. And so we worked with the group that kind of developed this, Dan Oringer and Tom Holland at Michigan, NYU, and Columbia, and we used our cohort together with all 4 universities to develop kind of a learning, a neural network learning system to look at all of these samples and to see if the computer could then actually generate the pathology of these tumors instantaneously. And so we published this in Nature together last in the fall. And again, pathologist on the frozen was about 94% accurate, and the AI was about 94.5, 95 accurate. So equally accurate. And the interesting thing is that the inaccuracies in these two were completely different specimens. And so the ability to kind of even improve on the accuracy of both of them if they both work together was an interesting outcome. So what are some other tools to kind of achieve better resections in these tumors? I think we do use these port systems. There's 2 on the market, both BrainPath and the Vicor systems. We're not super aggressive with using these for deep thalamic lesions, but for other lesions that are fairly deep, we do use them pretty frequently, especially Mets. We did publish a series with us as well as Mayo Clinic looking at kind of the outcomes for not only gliomas, but Mets, cavernomas, and it does show that it's very safe. And we do think it causes less retraction and edema while you're taking out the tumors. There is some subtle techniques for using this for gliomas. Specifically, you're always working inside out. And so really understanding the tumor margins and being comfortable with what is tumor and what's normal brain is critical. And the last part is laser ablation. And these are really for kind of the worst case scenario. So tumors in the deep basal ganglia or even brainstem, or patients that have recurrences that are already on multiple chemotherapies or have radiation effects to their skin, have comorbidities, and are really not good surgical candidates. And so we've been using LIT for almost 6 years now. We probably have about 200 patients that we've treated. We've done multiple studies showing that laser for both newly diagnosis does show very similar overall survival in these patients. I mean, these are patients with deep thalamic lesions, so mean overall survival of 14 months is similar to what the published data is for those lesions, and also for recurrent tumors as well. And then this is our series published just on deep tumors, such as the one pictured here, a deep splenial lesion here, which was treated with a unilateral approach with a laser. And I think everybody has cases of a few of these tumors, with small ones especially, where they show that it's 30 or 60 months and the tumor hasn't recurred. We definitely have a few of those, but obviously it doesn't happen in all cases. All of these tumors still get chemotherapy and radiation, and it's still difficult to determine who will benefit from this and who won't. This is our case series of 100 patients of just brain tumors. We also use this for epilepsy, showing that for newly diagnosed gliomas, our overall survival was 20 months, and for recurrence was 7 months with this series of 25 patients. We also showed that, much as the Cleveland Clinic group also showed, that extent of lesion ablation is just as similar to resection as it is with laser. And so when you achieve a greater than 85% ablation, patients do better. And this works in all kinds of tumors, not just gliomas, for Mets and radiation necrosis. So, but here's an interesting case that I pose for people who are kind of a little bit, questioning how laser works. And I think there's more than just the laser burning the tumor that's going on. Here's a patient of mine that presented last year, 47-year-old lawyer with right-sided weakness, who presented with this very challenging butterfly glioma. I think that it's obviously next to all the cortical spinal tracts, which is why he was having early weakness. He had hydrocephalus, which had to be taken care of as well. But instead of just doing a biopsy and shunt, which I think is what a lot of people would do, we did a laser ablation. I knew that I wasn't going to be able to get a 90 or 80% ablation, but I thought that if ablating the tumor that was closest to where the cortical spinal tracts would be, and as much as I could on the left, which is where the bulk of the tumor was, that it may provide some benefit to him. So here's what our trajectory was, and here's what the ablation zone looks like. And then here's 3 months, what his tumor looked like, 6 months and 9 months. And he was an IDH1 wild type, not unmethylated tumor. And so, why is his tumor responding like this? Is it the laser, or is it just the fact that he happened to have a good response to all the adjuvant therapy that he's gotten? And it's hard to say. I mean, I think we don't have the answer to that. Some of the things that we've looked at is there kind of some immune reaction that's happening in these tumors? We looked specifically at the neutrophil lymphocyte ratio and how that ratio changes preoperatively to post-ablation. And what we did find is some people who are able to kind of have a bigger change in their ratios are people who have been maybe more immunosuppressed and less immunosuppressed, and therefore they're able to kind of generate this immune response to the laser. And then obviously there's another paper talking about how it breaks down the blood-brain barrier, Eric Luther's group in WashU, showing that, and this is not the paper, this is the paper here, showing that it does, in fact, increase the blood-brain barrier breakdown. And so if you are able to optimize that window and give chemotherapy during that time, can you have a better effect on these tumors than without doing laser? And again, I think there's about 5 clinical trials looking at this specific question right now, and we'll get the answers shortly. As far as what's upcoming with advanced neuronavigation, I think it's the biggest thing is bringing this more into the operating room with virtual reality and augmented reality. So I know surgical theater has been doing a great job with making these preoperative images here. We don't have that, but we have another system. The Leica system and Zeiss have also kind of built in this 3D kind of augmented reality of overlaying the fiber tracks to give you more real-time feedback. And I think eventually this is going to help us with making surgeries quicker, as well as less risky by constantly reminding us where critical structures will be. Here at Miami, we're kind of taking a little bit of a different approach. We're using augmented reality with glasses where you can actually see in real time the patient's head and kind of their tumor, as well as the arteria and venous structures, and we're building into the tractography now. And that allows you to kind of not need the microscope, but actually just use goggles to actually see these 3-dimensional objects as you actually resect tumors during the surgery itself. So overall, I would say that greater extent of resection is key for all gliomas, including low grades, high grades, GBM, and multifocal. Obviously, the data for multifocal is limited, but I think that as we learn more, we'll identify that it is helpful. There's definitely categories of where the thresholds that offer benefit to these patients, and 80% is definitely a key threshold that's been described almost 20 years ago now. But beyond that, I think we'll also find additional thresholds of percent of the flare and beyond in the supramaximal resection. But we need to understand exactly what are the cognitive and neurological changes that occur in these patients. And I think that's the next thing to understand as we learn more about the human connectome with kind of artificial intelligence, which is what's brewing. We'll be able to correlate as to when is it appropriate to push the boundaries as much as possible, and when it is to go for more of the 80% resection in order to provide the best benefit for which patient. When supramaximal resection is able to be performed and safe, I believe it is preferable to do this. Of course, more importantly than any of these is to prevent any neurological morbidity, and to do that during a surgical resection mapping is the number one key thing to kind of prevent that, especially for glioma surgery. I'd like to just put a short plug in for our Miami Global Brain Tumor Symposium, as well as our cerebrovascular skull-base symposiums, which happen on Wednesdays and Thursdays. Next week, we'll be talking about some of the advances in brain tumor and glioblastoma. Dr. Carter is a great research endeavor looking at liquid biopsies and exosomes, and I'm sure he's going to be talking about that. So very excited about his talk. So if you're interested in hearing those talks, you can always go to our YouTube channel at University of Miami. All the lectures are recorded and put up there. In addition, you could sign up for the lectures. There's a registration at our website, which is down below, or you can visit us on social media and then get the emails to join those at any time. If you have any questions, I'm happy to answer them now. Also, you could always reach me, email or on social media. Happy to respond to you, but I definitely would like to entertain any questions that you may have.
Thank you very much, Michael. This was a very nice presentation on high-grade gliomas. I don't know, I feel that sometimes there are many steps where you can fail, right? I mean, there's no perfect answer for all the questions we have around glioblastomas, mostly. It depends on the age of the patient, the location, the radiation. I mean, there are many things that we don't know yet what's working and what is not working. I don't know if you have seen that there are some patients that you can achieve a gross total resection and they live for a good survival. I mean, almost 10 years, and there are others that where you get also gross total resection and just 6 months. Sometimes I feel, that there are many things that you would like to do, but sometimes maybe a gross total resection, if you're risking, maybe it's not worth it, right?
Yeah, no, I mean, I definitely agree that when you're putting the patient at risk for a gross total resection, it is, you definitely have to think twice about, are you really offering benefit for this patient or not? And so, I think that's why there are some series now that really talk about aggressive surgery for thalamic and basal ganglia gliomas. And I think that that's tough because you have these perforating arteries, which we just don't have good enough imaging to see. And they can be easily taken, and then all of a sudden the patient is plegic or obtunded, and you definitely didn't do that patient any service by doing their surgery. But I think in the other areas, the surgery is quite safe overall. I mean, I think our glioblastoma patients that we choose to operate on, like I said again, about 85% of them are leaving on the day after surgery and going home. And so if you could, and then if we look at our laser series of gliomas, which is probably about 40 patients now, I think all but one of them have also left on post-op day 1. And so if you could offer these tailored approaches and have minimal impact on their quality of life and get them back to their life and understanding, in their normal life, and things that you do like minimal hair shave and, minimal exposures, more smaller incisions. These people have a short time of life left, and you're right. You definitely don't want to take up weeks and months of their life because they're stuck in the hospital dealing with some kind of complication. So we do need to push the limits, but as long as we're able to minimize those issues of quality of life is key. As far as the heterogeneity of tumors and predicting who will do well and who won't, yeah, I mean, I agree. I mean, I think that we're only scratching the surface of the molecular subtypes of glioblastoma. I think that as we learn more, we're going to find out there's many, many, many other types of glioblastomas with lots of different ranges of outcomes. And to think that there's 4 subtypes of glioblastoma only, or 5 subtypes, or however you want to, group them, is just silly because there's so many, molecular mutations that are happening both initially and then as you undergo each treatment, and how that tumor is responding to each one as it goes. It's very challenging to predict how that person's going to do. But I think as surgeons, we see them the first, right? So we don't have a lot of data as to know what is the trajectory of this tumor. Is it fast growing? Is it slow growing? Is it a lot of edema? Is it not? Is edema happening fast? Is it not? And so we need to make that decision up front. And I think, because we can't tell definitely, who will be the long-term survival and who won't, offering them the best surgery up front is critical.
Absolutely. I'd like to know if I can share some cases with you. I would like to have your opinion
Sure.
about how you like to do, a safe resection in these cases. So I will share my screen right now.
Okay, I'll stop.
Right, there you go. So these are some high-grade gliomas. So this first case is a 60-year-old engineer with seizures, and so we have here, this butterfly glioblastoma, and I'm pretty sure that you feel when you see these tumors that you probably won't have, a good resection even if you do a bilateral craniotomy. So by this time, what you would like to do for such patients, like this one?
Yeah. I mean, again, extremely tough cases. I totally agree with you that whenever you're talking about doing surgery on both sides of the head, you really have to second guess yourself. So, I think in this case, he doesn't appear yet to have hydrocephalus. We don't have the temporal lobes, but on the coronal cut, you don't see any temporal ventricle entrapment. And so, as far as debulking the tumor, I think that would be the primary indication, is if you find that both temporal lobes are entrapped because the CSF isn't able to get from the anterior ventricle to the temporal horns. That would be important to kind of make that connection. And that would be one indication in this case to try to do a resection. I think at our university, what we've started doing for these is to do bilateral laser ablations in biopsy. And then, if he develops hydrocephalus, you could deal with it at that time. But in our laser ablation, as we look at the volumes, they typically don't have that much expansion of tumor immediately. And again, we really haven't seen any deep hemorrhages from treating these. And so, the risk of doing the laser ablation in this area is fairly low. But I think that the risk of surgery is quite high.
That's a very nice. We don't have access yet to laser ablation. Unfortunately, we don't have yet I think in Latin America actually.
Mhm.
Yeah, so we did just a biopsy on this patient. We tried to do a parietal approach. So this was a glioblastoma, and we tried to do it in the best way we try, in order to avoid damaging this patient. So this other one is a 60-year-old man, also with seizures and left paresis. So for this case, I just would like to to discuss. I was talking to Dr. Commodore last week that it depends also on the surgeon. Where do you decide when to do wake surgery for those cases that probably Dr. Dufault maybe would like to to do all of them wake, but
Mhm.
probably most of surgeons just will do a sleep craniotomy for such as these cases, right? uh, I was scared for this one in specific, that it was pretty medial, close to the cerebral peduncle. So I was trying to go very deep, as much as we could. What do you like to do for this case?
Yeah, I mean, I think this is what was the week? How weak was the patient before surgery?
So he was like 3 out of 5 in
Yeah.
yeah.
So, I mean, I think in this case, again, you're not, the idea of trying to do a lesionectomy and just take out the uncus and hippocampus is kind of a moot point, especially on the right side. So, in this case, a full temporal lobectomy would be key. And what that will allow you to do is to, see in front and behind of the tumor, especially as the PCOM and PCA kind of come around the side. I found in these tumors, especially in this location, that they don't respect the arachnoid boundary in the medial aspect, and so the the tumor being potentially attached to the peduncle, as you said, or encompassing, encasing those perforators off the PCOM could definitely be occurring. And the last thing you want to do is to cause an infarct in them because you just complete his hemiparesis. So I think that if there is not a plane, I would leave a small carpet that would be kind of in that arachnoid plane where the perforators would be. If there is a good plane, then I would just work gently to try to peel the tumor off. As far as superiorly, I find a lot of times that even though this looks like it's going up into the temporal stem, when they do that, I find that they are pushing the brain upwards, and so uh, the weakness is hopefully from a lot of edema, and but mapping awake with somebody who's already a 3, there's a risk that they would be even less, they would be more weak being asleep. And so even I'd probably do this when asleep, but if I would do it awake, I would have a backup MEPs available in case we woke him up and he was completely plegic. And then what do you do with that situation when they're awake, plegic, and you don't have map? You're not able to map. So you have to have, when they're that weak, or when they're talking that weak, you really need to have a backup plan with MEPs.
Yeah. So we did, a T2 T3 approach. And we get a good, resection over there, but this tumor actually had a capsule. But when we did this post-op MRI, we said that all the caudate was infiltrated. Unfortunately, in the pre-op, sorry, I don't have it here.
Yeah.
There was like an infarction. It looked like a restriction in the DWI. So we thought that he had both an infarction and
Yeah.
tumor, but unfortunately, it just converted to this piece of tumor in the caudate. So unfortunately, the patient, had in this case a partial resection. But I think it's, for me it was enough, because you probably won't get this part of a tumor, right? I mean, probably you will get.
Yeah, you won't. You're just trying to provide, as much mass effect relief as you can, and so, making sure that you're knowing that you could predict where pretend the caudate lesion wasn't there, because it's hard to know if that's. I mean, it looks like it's tumor, but an infarct would also enhance at certain time points. But it's gonna recur above that area, and so providing as much empty space to allow that recurrence to occur without pushing upwards is good. And I think you've done that here by removing a large amount of the temporal lobe there.
Yeah, absolutely. I have a question, because I feel that in the US, most of people, discharge patients like in post-op day 1 or post-op day 2 is, but I don't know. At least us, we feel that the edema, that the postoperative edema is, when you have a subtotal or partial resection, is a very risky thing for just discharging the patients.
Yeah. I mean, I think that for people who aren't doing well, we obviously don't discharge them post-operatively. As far as the Decadron, we do a little bit higher of a dose here for our glioma patients. So 10 in the operating room, and then 10 Q6 for the first 24 hours of Decadron, and I think that does help a little bit with that first round of edema that you're talking about in the 24 to 48 hours.
Yeah.
But there are certain patients that have large tumors where you have a lot of flare that you weren't able to resect, and you're worried about post-op edema, and you do have to watch them very carefully.
Yeah, we feel that probably we have to stay with patient for at least 3 or 4 days. We, for the first 3 days at least. It's something that we do in our school. I don't know. Well, probably changes a little bit between one institution and another, but yeah, we're always concerned about that edema. So this is the last case to finish this lecture. Thank you very much, Michael, for your time. So this 50-year-old male with, female with left hemiparesis, and this is the tumor she had. So well, at least for this MRI, we thought at first we had a glioma, right? A glioblastoma, most likely. So this is a little bit different, right, from the other cases. So I just tried to show you different cases, but because I think it's a puzzle where you have to pick the pieces and try to take them which are good for each case or not. So
Yeah.
what you would like to do for this one?
And again, how weak were they?
So 50-year-old left hemiparesis. So she was like a 4 out of 5.
Yeah.
Only.
Yeah.
She was good.
Yeah, sometimes with these large tumors with a lot of edema, we'll even I personally will admit him like an extra day early to give him extra steroids and mannitol for 24 hours before surgery, and that allows that peritumoral edema to go down and allows you to really understand how maybe their strength will get better before surgery, and that will kind of help predict with how much of the tumor is invading the motor or not, and if they get better with Decadron for a day and mannitol the day before surgery, then that tells you that the motor cortex is probably pushed to the side. If they don't get better, then it's probably eroded. One interesting thing, just because this is a large tumor. But again, obviously, it does come to the surface, it appears here, although you always have to be prepared that it doesn't. You get your preoperative DTI tractography, functional MRI if you can, and then agree. I mean, so obviously the number one priority is to stay out of the motor cortex, especially it looks like leg is probably preserved, but hand and face is probably more involved. And then the question which of always is debated is what do you do with the sensory cortex on the posterior part of the tumor? Is that eloquent or not? And we tend to be fairly aggressive with taking the sensory cortex here. And sometimes people do really well with that, and other times it really makes it very difficult for their step when they don't have proprioception coordination afterwards. But I think in here, this case, probably everything is pushed to the side. The goal would be primarily just to get the contrast enhancing tumor, not to do like a maximal a super maximal resection in this case. But I think even though it's wispy, a lot of that you could get out.
So, would you like to do an awake or an asleep craniotomy for this case?
Yeah, I would do it awake.
Awake, right? Yeah, that's another concern I have, because sometimes when you're not trying to map language, that I was talking also to Dr. Commodore that I mean, you can do it also asleep, right? But I don't know exactly if it's good or not in these cases that are so large, even if they are not in the left side, right? But well, it's good. So we map this case. So the motor tracks were that we have here the pre-op and post-op tracks. So these are the pre-op and the post-op are lined in blue. So we mapped, and as you said, we had the upper limb here, over here. We didn't find actually the face, but probably would be like here. This is medial, right? The sinus here. This was a tumor, so we had to leave a little piece here, because when we were mapping, there was a part of the hand here cortically, and if you see, this is the post-op, for that there was a little bit of blood here. but this was the pre-op and this was the post-op, and this blue thing here is the residual that we left there because it was pretty close to the, as you said,
Yeah.
in your,
No, I agree with that.
yeah. But I think we measured that, and it was like 95 or 96% of resection that was planned, at least.
Yeah, I mean that's a great resection there, and again, I mean, you know, you just said the importance of not only mapping the cortical surface, but you could see how this fiber track is coming all the way down the middle aspect of the tumor, and you know, mapping the entire subcortical aspect of that tumor is going to be critical. You know, when we do these awake, like I said before, we always have a backup plan. We always have neuromonitoring in the room. We a lot of times we do MEPs. We put the patient to sleep, do an MEP check, and then wake them up to do the awake part. And so even if they don't tolerate it, if for some reason, like you said, the tumor is too large and mass effect is a problem, we could always put them back asleep. But in this case, I wouldn't be too worried about too much mass effect.
Yeah. So for these cases, I feel that probably all this edema is tumor, right? Or probably it's infiltrated. So you're going just for the highest grade of tumor. Unfortunately, you're not getting a gross total resection in these kind of tumors.
Yeah, I mean, no, we're not trying to get a gross total resection. We're not trying to get a maximal resection when they're located in the motor cortex like this. And you know, as far as what is going on in the flare, I mean, there's a couple things that could be happening. I mean, it could be a lot of it could be edema, probably not, but it could be. And then also it could be lower grade tumor, especially if it ended up being a mutated IDH1 mutated. I'm sorry, IDH, yeah, mutated tumor. You know, you're hoping that maybe you're removing the glioblastoma compart and you're leaving behind the grade 3 or the grade 2 tumor behind. And so, you know, there's advantages to both of those, removing the active tumor or removing the highest grade, most malignant part of the tumor. And as surgeons, again, a lot of times we're seeing this first, and so we don't really know that. But you know, by knowing their age and the tumor and their ratio of contrast enhancing the flare, a lot of times you can predict what it's going to be.
Yeah, absolutely. All right. So
Great
thank you
job.
very much, Michael. This was a very nice lecture, and I would like to invite you to next year WFNS that will take place in Colombia, hopefully.
Yeah.
If pandemic gets better, right?
Thank you. Yeah, we're all crossing our fingers that we'll be able to travel and see each other soon. I hope you guys stay safe as well down there.
Yeah. Thank you very much, and have a great end of week of this week. Thank you.
Okay. Take care.
Bye bye. Take care.
Bye.